welcome everybody. We have a nice group here today. And it's my pleasure to welcome Dr. Dan Smith. And he is a clinician scientist. He's actually a nurse practitioner with a Ph.D. and an endowed assistant professor, which is pretty amazing to have an endowed chair already as an assistant professor. And he's at Villanova University at the Louise Fitzpatrick College of Nursing. And during his PhD studies, he was a Robert Wood Johnson Foundation Future of Nursing Scholar, which again is quite a nice award. So his overarching research interest lies at really how to understand the effects of climate change on the health outcomes, particularly in disenfranchised populations, and then how we can build resilience, and particularly climate resilience, as well as adaptation skills in communities and health systems. He also has expertise on the environmental determinants of health, and he has been the academic lead for community-based participatory research projects, which is near and dear to our heart, and has been examining the impact of lead exposure on immigrant families in Philadelphia, and then heat exposure in migrant farm worker families in southeastern Georgia. So as I mentioned, he is a clinician, and he continues to practice 1 day a week. And so, which I find is just actually quite amazing to be such a productive and amazing scientist, as well as have a clinical duties. So without further ado, Dan, thanks very much for joining us.
No, thank you for having me today. And I'm super excited to be here with you all and get to talk about this work. So I do live at this intersection of climate change, human health, and the multiple environmental determinants of health. But today is particularly exciting for me because the impacts of high heat conditions and occupational heat exposure are near and dear to my heart. They're really what got me into research as a PhD student. And today, I hope I can just kind of tell you the story of how we've worked with the Farm Worker Family Health Program, which is based out of Emory University in Atlanta, but has multiple academic partners to really kind of take some of this clinical work and what we're seeing clinically and move it into the research world. Today, if I can get my slides to go, there we go. Maybe it'll move. It's not going to cooperate. There we go. So before I get started, I will go through some of my disclosures. I am a board member for the Alliance of Nurses for Healthy Environments. So be what it'll be, that is the bias that I bring to this. I'm sure that I'm in good company, but I do have to make this disclosure nonetheless. I've received funding from the Farm Worker Family Health Program based at Emory. The Villanova University's Strategic Initiative for Climate Justice and Sustainability has also funded my work. And most recently, I've received a subaward from La Isla Network. So again, this is where the funding comes in, all nonprofit academic funding, no corporate sponsors to speak of at this point. For my talk today, I'll introduce you all to my team. I do believe it's very important that you all see the team, recognize that this work isn't done in a silo. The work that I'll be presenting about today is based in Southeast Georgia, but we have work that's going on in Nicaragua and North Carolina, here in Philadelphia. And I really think it's the team that makes this work special. I also want to discuss the impacts of climate change on farm workers. Again, heat-related illness, or HRI, as you'll see throughout this talk, is my particular area of focus. However, as you'll see, really having to now move my own science into a world of true climate change and health research and not having that luxury of being able to specialize in one specific disease process. I will tell this story by discussing the research trajectory of the Farm Worker Family Health Program, leading you through some of the different projects we've done related to heat-related illness first aid with the workers, a train-the-trainer intervention that we developed and tested last year, and then kind of our first analysis of some of our clinical data through climate change diagnostic clusters. And then we'll wrap everything up by talking about our next steps, where we're going and where we kind of see this work as not only as Dr. Smith, myself, my own program of research, but as a program and kind of where we want to take this work next. So this is the lovely team that I get to work with every day. We span ECU School of Nursing, Emory School of Nursing, and Villanova School of Nursing. You can see I do have that bias of being a nurse. A lot of my team are nurses. We do have quite a few public health prepared people on the team. Dr. Mack has a PhD in environmental health, and Kayla Rogers, our first student for the Farm Worker Family Health Program, has an MPH that she completed her thesis with us. But again, I could not do this without Dr. Liz Mizell at ECU School of Nursing, and also a member of the Alliance of Nurses for Healthy Environments, Dr. Lori Modley, really relying on her DNP and that quality improvement kind of thinking that she has for some of this work. And then again, my own research assistants at Villanova, Anna Smith, who is a pediatric nurse, and Jocelyn Zavala Garcia, who is one of the undergraduate students who's worked with me, not so much on my farm worker stuff, but our work here in Philadelphia. But again, CBPR, we use those skills for both of these projects. So I'll start out today by talking about climate change and farm workers. I assume that the impacts of climate change and health are not new topics to this group, but I will start out just by reviewing the CDC will. The CDC will is very much the theory that drives my work. We're really kind of thinking about the impacts of the climate at the center of this wheel, rising sea levels, increasing carbon dioxide levels, rising temperatures, more extreme weather events, as being the climate things that are occurring in our day-to-day lives that are causing negative health outcomes. My own program of research, I like to split this wheel into two. And this side over here with changes in vector ecology, increasing allergens, water quality impacts, and water and food supply impacts are not so much where I live. I live very much in this extreme heat, severe weather, air pollution, and environmental degradation piece of the wheel. So a lot of what we'll talk about is on this side of the wheel, with most of the emphasis being here in the extreme heat, with heat-related illness, heat strokes, heat death, cardiovascular failure, acute kidney injury, and all the various sequelae that you can have from living, and more importantly than living, but working in an environment where you are exposed to extreme heat on a daily basis. So heat-related illness, for those that may not know, is a continuum of symptoms. We think of heat-related illness as starting in the opposite of the most extreme. So that extreme thirst, nausea, vomiting, cramps, all of these signs and symptoms that farm workers can know about in order to kind of say something is going on with my body. I need to stop and reassess. Those symptoms such as thirst, nausea, vomiting, cramps can then start progressing into that greater thermoregulatory dysfunction that leads to heat strokes and ultimately death. Farm workers are particularly vulnerable to heat-related illness, with undocumented crop workers being anywhere from 20 to 35 times more likely to die of a heat stroke at work than civilian workers. This has to do for a multitude of reasons that we'll get into on the next slide, but this disparity is just in your face all of the time whenever you're both practicing and doing research with these communities. We also know from previous work that we've done that farm workers themselves are often unsure of how to identify and respond in the workplace to heat-related illness. No one has ever set them down as a part of their onboarding to their jobs. They likely do not get an onboarding process as you or I, being privileged academics, would be used to say, hey, you're working in these hot conditions. These are the signs and symptoms you need to watch out for. And farm workers just don't know what they don't know, right? We also don't have a federal heat standard. So we have certain states, California and Washington out on the East Coast, that have state level heat standards that say if it gets above XYZ temperature, then we need to make these certain changes in the working day. However, at the federal level, there is no such heat standard. And actually in certain states, thinking of Texas, there have been laws that have been passed that said no more stricter heat standards can be enacted at the local level than what the state has. And the state doesn't have a heat standard, so it basically bars even local municipalities from passing laws to protect workers. Some of those additional factors at play that make farm workers more susceptible to heat-related illness are their compensation levels. So whenever we think of compensation, most jobs that you or I would have are either going to be paid on the hourly basis, so you get X amount of dollars for every hour you work, or you're going to be salaried. Farm workers have to work and be paid by the piece rate in most instances. There have even been studies that have, and the piece rate is, I'll explain that, I'm sorry for jumping ahead, but is the more you produce, the more you get paid. So if you think about collecting a bushel of apples. For each bushel of apple, you get $1. So the more bushel of apples you collect in a day, the more money you make. So that incentivizes workers to work harder, which causes more endogenous heat stress. So we think of there being two levels of heat stress: exogenous heat stress, or what the environment and the environmental conditions cause in this thermodysregulation process, and then also endogenous, or what the body's own metabolism, because whenever you're going through metabolism, heat is a byproduct, and that endogenous heat stress is particularly increased for workers who are paid by the piece. Farm workers often have decreased access to healthcare for either being an H-2A visa worker who is new to the country, not sure where to go for their care, fear around accessing care if they're undocumented, fear around having to suffer a great financial burden from accessing care if they're undocumented, don't have insurance. So there's this decreased access to care that also plays into it. We do have cultural differences. We have to think about our farm workers are not a homogenous community. For example, I was a nurse practitioner out in Kennett Square, which is the mushroom capital of the world. And during my time there, we saw more and more Hmong farm workers coming. And the Hmong are an indigenous group from Guatemala, and they don't speak Spanish in a lot of cases. And so even these cultural and linguistic differences, where our services at the FQHC that I was working at the time were very well tailored to our Spanish-speaking Mexican farm workers, because that was the predominant community, the predominant population in the community for many years. Then as we're seeing more Hmong-speaking farm workers, we really weren't sure how to react and how to navigate that as a healthcare unit. So those cultural differences can come into play. There's also housing issues. So for H-2A workers in particular, and the H-2A program is a program that brings seasonal migrant workers primarily from Mexico to the US to work for a season until a crop is picked. And then those workers at the end of their season can migrate back to Mexico, or may even be moved to different farms around the US, depending on how big the farm they're working for is. And particularly for those migrant workers, their housing has to be provided by the farm that they're working on. And those housing conditions are horrendous. Some of the ones that we've seen in our clinical practice, these workers do not have air conditioning at home. So even they've spent all day out in the field working, they're hot, they're sweaty, they come home, they take their shower, and then they don't have a cool place to get any relief from the heat. Sometimes these conditions can be, these housing units can be really bad, in that their mattresses have holes in them. They can be infested with rodents. So you have all these different pieces of the housing that are also causing this exacerbation in HRI. Again, those compounding occupational stressors of not only are farm workers exposed to heat, they're exposed to pesticides, they're exposed to different layers of power and control based on the farm they're working for has contracted out their employment to a third party. And so all of this kind of comes together to make this perfect storm for farm workers. I'll point you to a report that was published by Watson, McElvin, and Holst in 2023. This was a joint report that was produced by La Isla Network and the Environmental Defense Fund that does a very deep dive into some of these socio-political factors that impact farm workers' susceptibility to heat stress, if you're interested in learning more. So now I get to jump into the fun part. But before I do that, are there any questions about the background, the setup, any pieces that you need clarification on before we move on? And I see we have one chat. I'm just going to check it real quick. Okay, it's not for me.
So Daniel, I have a question about like what age range you see those farm workers? Is like middle age or a little younger? So how's that?
Yep. So it's really interesting that you asked that, because you would think, oh, I'm an adult gerontology primary care nurse practitioner. Why am I a part of a children's environmental health collaboration? We see farm workers that start particularly in some of the international work that I do that are starting to work as young as 13 and 14 years old. I would say the bulk of the farm workers that we work with in Southeast Georgia are between 18 and 30 years old. We do have some of our true immigrant farm workers who have immigrated to the US that get into that middle age range. But for the most part, it's really 18 to, and I would even say 30s high. It's probably 18 to 25 is the bulk of the people that we're working with.
Thank you.
Anything else? Happy to clarify. Okay. If not, I'll move on and I'll start talking about the Farm Worker Family Health Program. So the Farm Worker Family Health Program is based out of Emory. It has been around for 31 years and counting and has the primary goals to both train students in providing healthcare to disenfranchised, underserved populations such as farm workers, but also to provide healthcare as an extension of the migrant farm worker clinics that are in Southeast Georgia. We began research in 2018, and I'll talk a little bit about what sparked that on the next slide. And then we had our first publication in 2021. So research is kind of our side gig that we do with our primary goals to be train students and provide clinical care to farm workers. However, we can have all the best laid out plans and goals in the world, but in 2018, while we were in the fields of Southeast Georgia with students, there was a farm worker death. A 24-year-old brand new to the US and just come from Mexico, not even been in the US for 2 weeks. And I'm sorry, this should say less than 2 weeks, not greater than 2 weeks, died of a heat stroke in the field. The heat index, which is a combination of the apparent temperature and the humidity, the day that this worker passed away was 104 degrees Fahrenheit. There's different reports of what happened the day this worker died. There have been reports that workers were taking breaks every 30 minutes. There have been reports that said they were not taking breaks at all. But what we do know is that there was an attempted resuscitation in the field by some of the supervisors and the other workers. However, unfortunately, this attempted resuscitation was unsuccessful, and this farm worker was pronounced dead whenever he was arrived to the hospital. Also, we know that being in Southeast rural Georgia, there are some systematic factors at play. It takes, on average, twice as long for emergency medical response to arrive to the scene of a rural emergency as compared to our urban environment. However, in Georgia, we see sometimes, depending on how remote the farms are, it can take an ambulance 45 minutes to 60 minutes to arrive after being dispatched. Kind of knowing all of this together and with the strong hold that the Farm Worker Family Health Program had in terms of community relations, we were approached by multiple key stakeholders and asked us for help. They wanted to know better what happened, what could be done potentially to intervene to prevent additional farm worker deaths. And that's where this first study came in. We call it the HRI First Aid Study. This is my colleague, Dr. Mack, and I. You can see we have our research table set up in the middle of a cornfield. If this picture were continuing to the right, there would be a field of corn. And we surveyed 60 farm workers in the period of a week in South Georgia. And we just wanted to know, were they experiencing heat-related illness symptoms at work? What was their hydration status? How much water were they drinking? And what were they drinking? And then also, did they know the proper steps to do heat-related illness first aid? The most surprising result, and I left it off of here, is that none of our farm workers could accurately identify half of the first steps that we asked, the first aid steps that we asked about on the survey. And that's really shocking, seeing that 2/3 experienced at least one heat-related illness symptom while at work, with over half of our population reporting more than 2 heat-related illness symptoms while at work. The most common symptoms reported were heavy sweating and muscle cramps. And then these farm workers were also drinking, on average, they were reporting 72.95 fluid ounces of fluid intake per day. Now, that fluid intake could be anything from Coca-Cola to Gatorade to Red Bulls to water. And that's one of the limitations of kind of guesstimating this number, is that we were asking for self-reports. However, whenever you look at what is recommended for the hourly and fluid intake for people that are working in outside extreme conditions, and this number always freaks people out. And if I have any nephrologist on the line, I promise I'm not giving your patients on a dialysis unit this amount, but we recommend that it is at least 32 ounces of cold, clean water per hour while you are actively working outside in the heat and sweating. And if you can see that people were reporting, our farm workers were reporting 73 fluid ounces a day, they are much below that threshold. There are multiple reasons why. A lot of the farms, the bathrooms are far away and they can't take time off if you're being paid by the piece to go relieve yourself if you're drinking water. Some of the farms may or may not be providing clean water. Some of the farms may be providing Red Bulls in their farm shops that their farm workers can buy their supplies from. We didn't investigate that, but we just thought it was really interesting. Now, from this study, we knew that we had this lack of knowledge, and we can argue all day long about how good patient education is, right? Particularly with a population where there are so many systematic factors at play that cause the disenfranchisement, the vulnerability, right? However, if it is taking 60 minutes for emergency medical response to arrive to a farm, it is, we thought, a worthy effort to try to train our farm workers to respond to heat-related illness, recognize the symptoms, and then adequately respond in terms of cooling off very quickly. Where were the appropriate anatomical locations, such as the back of the neck, the groin, the axilla, in order to apply those ice packs. Again, best laid plans can happen. We did this study in 2019. Our planning started in 2018 after the death of the farm worker. The study was carried out in 2019, and in 2020, when we were going to train farm workers, we could not even get access to the camps due to COVID restrictions. So 2020 came and passed, 2021 came as well, and that's when this publication came out. But again, 2021, we were really just being welcomed back to the farms and weren't really trying to do research. Again, that clinical care being that key goal, we put the research on the back burner so we could at least get down to the fields of South Georgia to take care of the farm workers again. Lo and behold, in 2021, while we were down there, we had another farm worker die. So we said, we have to do something about this. If we can't get access to the workers to provide one-on-one trainings, we're going to do a train the trainer model. And that's where our next publication came out, which was a train the trainer model in which we developed an educational intervention, an hour-long PowerPoint for both our pre-licensure BSN registered nursing students and our post-licensure APRN nurse practitioner students to train them on the physiology of heat-related illness, how to identify the signs of heat-related illness, what the first aid measures would be, what the clinical treatment would be, and how they could do patient education around identifying and responding to heat-related illness. Luckily for our students, they had an increase in knowledge compared to baseline. You can see our BSN students went from 61% to 93%, and our nurse practitioner students went from 69% to 96%. Now, again, this is great. We train these students. We have now made this a required training every year, hoping to disseminate knowledge from this train the trainer model. However, we do recognize that we're still not getting to the farm workers themselves, and that's something we're actively trying to develop, those community partnerships, hoping that we can train the supervisors, the foremen, some of the workers themselves that are there year after year, how to respond to heat-related illness. So again, those implications, we need to really be tracking these educational interventions to the health outcomes. That is the future area of this work, I think, would be saying, if we train farm workers, do we have less heat-related illness? Are they better managing their hydration intake while they're simultaneously living in these systems of power and privilege that we're working to change back in Atlanta? We always say, we do clinical care in Moultrie and we save our advocacy for Atlanta, so that we're working with farm workers that have very different political beliefs than a lot of the academics and clinicians. So we have to toe that line if we're going to be welcome back in the community. One idea that we're exploring is the use of extension offices. So can we get our extension offices involved and have them help bring farmers and supervisors and foremen to the table so that we can provide training that stays into the community, more so than just training our nursing students to come in for 2 weeks out of the year to disseminate some of this information through patient education. Now, this all got us thinking, well, we know that heat-related illness is happening, but what about all the other pieces of climate change? If we look back at that wheel, climate change is more than just one of the 8 sections, there are all these other pieces where we could potentially have negative health outcomes due to climate change. And that's what led us to finally use some of this clinical data and do a secondary data analysis. In 2018, we had a new database that was developed and implemented for our data collection needs. We had, up until 2018, for 25 years, the program had been storing all their data on CSV files. And my lovely colleague, Dr. Lori Modley, for her DMP project, designed a database and implemented it as our electronic medical record. So we did 2 years of data in a collection. So in 2019 and 2021, we collected data as we were seeing patients in the field. And then I put my researcher hat on and was like, how can we use this data to see what is going on the farms? Are there differences? We knew that we were on different types of vegetable farms, from farms that were primarily doing corn to farms that would do melons, such as cantaloupe and watermelon. We even had a couple of berry farms. And so I was really interested in kind of knowing what the differences in those farms were. And so using our new database, I applied k-means cluster analysis to analyze the diagnostic clusters of the top 20 diagnoses that were being made across the 5 farms. We had a total of 134 different diagnoses that had been made across those 2 years, and they were made in 987 farm workers. So we had almost 1,000 farm workers that we did this analysis on. And what we found is that we had 2 distinct clusters of farms. So we had farm A that is up here in the corner, and we had farms B, C, D, and E. And the k-means analysis showed that there was something particularly unique about the diagnoses that were being made. If we look, our first cluster from farms B, C, D, and E, you can see there's a much more bigger variety in terms of the diagnoses that are being made on those 4 farms. Again, kind of expect that we're going to have a lot of musculoskeletal. Over 50% of the diagnoses are musculoskeletal. However, what I'll point out is our malaria, or our heat rash, that prickly heat rash that comes from working in the heat and the sun, and our pterygiums, which are overgrowths on the eye, which have been linked to climate change due to increases in pollution and solar radiation and how that's interacting with the different levels of greenhouse gases, are fairly low in this sample. Headache as well. That's one of the common kind of HRI symptoms that our students, they don't really pick up on it being HRI, but they know the farm worker is coming to them. They have a headache, and then the farm worker reports that they've not drank a lot of water. So it gets coded as headache, but we suspect that this is more of a headache due to HRI. But if we compare this to our second cluster, or farm A, you can see that we have a much bigger percentage of what I call these climate sensitive diagnoses. We have a much bigger percentage of pterygium, prickly heat rash, and headache, and a smaller percentage of these musculoskeletal disorders. What we think is going on here is that Cluster 2 is a berry farm. So strawberries, blueberries, blackberries, whatever berry is in season. And the harvesting of berries is quite unique compared to some of the other vegetables. The other vegetables, such as cucumbers, cantaloupes, are picked off of the vine and then transported by hand to wherever they're being stored, the tractor that's taking them back to the sheds. Berries, there's literally, I like to call it's a metal rake essentially that has a bucket attached to it. And that requires the farm worker to bend over and sweep this metal rake through the berries to pick the berries off the vine in the most efficient manner while also not destroying them. So my hunch is that that has something to do with it. But again, we are scientists. We don't just go off of our hunches. And really got to now do more studies to understand what is unique about these berry farms and what can we do to intervene to protect these workers if we're seeing greater concentrations of heat rash, greater pterygiums. What is going on and what can we do to protect workers? Again, I think it's the harvest method. Could it be their housing? Could it be that they have less breaks? We're not really sure. Those are other hypotheses that we want to explore. However, k-means cluster analysis is a really useful tool for hypothesis generation. If you've never used it before, I really like that we were able to apply it to this data, and we weren't really sure what we were going to find, but it gave us a really good starting place for future studies. So our next question is, how do we now develop an intervention from this? And this leads us to our next steps and beyond. I'm really thinking, how do we continue to use this data? We've got our NHANES data that we're using. We have our first student. She's comparing indicators of nutritional status between our data and NHANES data. Luckily for Kayla, there have been no major differences in her preliminary results. She's still writing her Master's of Nursing thesis. She's got her MPH. So I won't steal her thunder, but now we're kind of seeing what we have no major differences, but perhaps it's time to do some time series analysis for program evaluation. The one that I'm particularly excited about, and this is what is building off of our cluster analysis, is doing some natural language processing. So we have all of these SOAP notes that we are collecting while we're providing clinical care. And a SOAP note stands for Subjective, Objective Assessment and Plan. And as a part of that, there are any other either advanced practice providers or physicians on the call, you know very well that we have our HPIs, our history of present illness, where we write out the story of kind of what brought the patient to us in clinic that day. It is the basis for running our physical exam, for making our diagnoses. And there's a lot of really good textual data that I believe we can start to mine to know what is going to happen or what is happening on those berry farms that makes them unique. So far we have a year of data. So we have about 90 farm workers who have been seen and have a complete HPI taken on them. Not all of the farm workers make it through to our nurse practitioner students. Some of them, if their complaint is primarily musculoskeletal, we triage them to see our physical therapist. However, in 1 year, we got 90 histories of present illnesses, 90 HPIs. We do plan to collect a second year of data in 2024 when we're back in the fields in June. And then once we have those 2 years of data, we'll be doing topic modeling to see, is there any difference in the history of present illness between our berry farms and our vegetable farms that might give us somewhat of an idea of where we need to intervene. I'm hoping that we can then take this again and expand on that and develop the intervention, implement the intervention, and then start doing that program analysis to say our intervention was successful. We prevented X% of climate-related diagnoses from being made after we intervened, and whatever this shows us the intervention is going to end up being. We kind of think, so all of this is farm workers in the US, but what about globally? The global farm worker population, and particularly when you're thinking about migrant farm workers, are just as important because farm workers may be moving from Guatemala to El Salvador to Mexico to the US to work. And if we're trying to have an occupational health and safety protocol, we all should be doing the same thing. Unfortunately, there is no data standard. It's the bane of my existence, and it has real consequences for data sharing. We've seen that in our analyses as we've been trying to compare NHANES data to the Farm Worker Family Health Program data, the differences in how our pediatric data has been collected with different updated pediatric growth charts from the CDC, what year it was collected, and this lack of standardization really kind of prevents us from comparing data sets. Personally, we have been trying to make sure that our data collection mechanisms have common data elements. We really would like to start doing some longitudinal data analysis with our pediatric population that is involved in the Farm Worker Family Health Program. But it also kind of begs the question of, should we be having standardized protocols? I think we should. I know some people like the flexibility in their research, but I really think if we're going to be moving the science forward, we need standardized protocols to say, if you're going to be working with a population and collecting data that describes the environmental determinants of health, this is how it should be done. We think about this again in my work in Nicaragua and acute kidney injury supervision protocols. So how are we preventing heat-related illness from becoming acute kidney injury and over time chronic kidney disease? Again, we can think about this kind of comparing different countries, different parts of Southeast Georgia to California even, and just some food for thought as we're going through our own research, and how you can apply a standardized protocol, I think is really interesting to think about and allows you to do some cool things with your data. So here are my references. I know that was quick, but I think most of the meat really comes from the conversations that we have after I always present this work. So I would love to just open the floor up for a discussion. If anyone has any questions for me.
That was great, Dan. We're clap here. That was really interesting. So we'll open it up for questions. I'm sure there will be lots. While we're waiting for people to think about things, I know Eamon asked a little bit about the demographics, and you alluded to sort of should you include children. So what are you thinking about, and what kinds of questions and what health outcomes would you look at in the farm worker families for children who might be impacted by that?
Yeah, so we always think about kind of the nutritional status, right? It's whenever we're on the ground in Southeast Georgia, we hear every year that the farm worker families do not have access to the fresh food that they are picking at work.
Yeah.
And so this idea of how can we make sure these children have access to healthy fruits and vegetables? And that's where the program itself has done a really good job at securing, providing the data from, we went through our CSV files for many, many years to be like, the migrant farm worker children that we have this data on, this is what we're seeing. And they've used that to produce a farm to table program within Colquitt County in Southeast Georgia. Other things that we think about are pesticides. I'm not a pesticide expert, but there are lots of things that you could get in there, right?
Yeah, sure.
The substandard housing is an issue, and if anyone's being exposed to lead, how do we deal with that? There are lots of opportunities.
Yeah, lots of confounding, but also interacting variables. I know Eamon and Ruth have their hands up, but since Eamon asked a question, I'm gonna call on Ruth first, and then you can ask your question, Eamon.
Thank you, Danielle. That was a really great presentation. You mentioned about adolescent farm workers. Do you have a large enough sample size of the youth that you could, generate some good questions and see what's going on with them?
Yeah, so that's where those adolescents are really the ages that we're missing, because how the program runs in the morning, we're at schools doing migrant summer school. So we get the kindergarten through like 5th grade, sometimes 6th, 7th, and 8th grade middle school. But by the time that you get to that high school range, a lot of those students have now become workers themselves. And so if they're not working on the farms at night and they're out working in the community at a restaurant, they kind of fall out of our data collection. We've got really good kind of on both ends. If it's the young kids, we have a lot of data on, and then once you get to like 12 to 16, 17, we don't have good data, but then we pick up the tail end of the pediatric years from 18 to 26 and have a lot of data.
Thank you.
Yeah. Eamon.
Okay, thanks. So my question, Daniel, is about the acute kidney injury from the farm workers from could be dehydration. So because an NIDDK is funding research in several developing countries in Central America and India to looking at potential cause of chronic kidney disease. And so AKI could be before that. So dehydration, pesticides, metals, all kind of things people are looking at. But I just want to ask you about, so if you have information about those acute kidney injury, so what kind of condition, how dehydration status would be for that to happen in terms of for that step to develop, that could be a critical step for us to understand in the etiology leading to eventually chronic kidney disease failure. So that is something, because I'm serving on the NIDDK OSMB observational study monitoring board on this study. So I'm curious to know more about how this situations you have experience with that.
Yeah, so it's really interesting, right? So if we think about chronic kidney disease of non-traditional etiology, we know that these workers don't have diabetes, they don't have hypertension when they develop their end-stage renal disease. And there's been all these different questions of, well, is it the pesticides? Is it metals? Is it the dehydration? And I think it's a chicken and the egg scenario. I think we've got the pesticides, right? We know that you're exposed to pesticides, but if you weren't dehydrated, maybe the concentration of the pesticides wouldn't be high enough to cause intrarenal kidney injury. So I definitely kind of looking at the data and knowing Sally and I, we just served as guest editors for Workplace Health and Safety for a global occupational health issue and got a really interesting paper that showed they did a time series analysis of pre-occupational health and safety protocols and post-occupational health and safety protocols to look at rates of acute kidney injury. And their protocol that they implemented was a water rest shade intervention. And so they had a really good they have all the pre-data that you need for epi and the post data. And they showed that this intervention is super successful in decreasing the rates of acute kidney injury. Not been going along long enough to see how we get with the chronic kidney disease piece, but just knowing that you can make workers have access to fresh water and having mandatory breaks in the shade at work can at least protect workers in some way, I think is compelling enough, more so from the clinical significance side, right, with my clinician hat of saying, we know that we have this cheap, simple intervention to protect worker health, let's do it.
That's
Yeah.
great to know.
Sorry,
Yep.
sorry, Eamon. Jess, you're next.
Yeah, the rates of pregnancy among the farm workers that was that data that you collected, and is that part of future studies? And how was that data looked at through you or others?
Yep. So we do not have data on pregnancy. We maybe will get lucky and we'll see 10 to 20 female farm workers every year. A lot of that has to do with particularly the farms that we're invited on all have a majority of H-2A visa workers, and that's just, it's the power and privilege at play, right? Where if a farm is employing H-2A visa workers, they're more likely to accept strangers coming in and seeing how things are run, right? And the reality is that a lot of those workers are young men from 18 to 26. Every now and then we will get a female farm worker, but it's very, very rare. I mean, again, some years we see none, some years we see 10 to 20.
That's interesting.
Yeah.
Arnold.
Yes, thank you. I was a nephrologist in the prior century. So, and I also have written an article on the toxicity of the energy drinks for health affairs. So my question is about the deaths. Was it determined whether they had risk factors either for dehydration or for excessive intake of caffeine that might have contributed to a cardiac arrest?
Yeah, so it's really interesting that you asked that. A lot of these, anecdotally, right? Like I've not gone into the death record, the vital statistics or anything, but what we hear on the street is that once it can be attributed to a heat stroke, that is what it is attributed to, and the main efforts and resources go to returning the deceased body to Mexico. They don't really have a lot of money for autopsies. They can't, a lot of times we don't have the health history of the person. And a lot of these people will die in that first 2 weeks before they've acclimatized to working in the temperatures. It would be really interesting to do that study, but in kind of how everything works, we just know that once it's attributed to a heat stroke, that's kind of where the issue ends in terms of the community and their investigation.
The other comment I have is there are several countries in the world where glyphosate has been banned because it has been shown in those countries to cause renal failure in the farm workers.
And it's interesting that you bring that up. So in my dissertation, I interviewed undocumented immigrants who had developed chronic kidney disease and were receiving emergent only hemodialysis in Georgia. So they were presenting to the emergency department for their dialysis sessions. And that's one question we asked was, had you used any chemicals such as glyphosate that cause kidney injury and kidney damage? And a lot of the workers in that study could not tell us what they were using at work because they were provided unlabeled bottles with chemicals and said, go do whatever. And so we quickly found out that unless we're taking these chemicals back to a lab and determining what they are, a lot of the workers don't even know what they're being asked to use at work and what they're exposed to.
Carla.
Yeah, thank you very much for your presentation. Very interesting. I was wondering if you could talk a little more about training the workers and supervisors. I imagine the workers are a pretty mobile group, but that seems like that would make a lot of sense to get the people that are out in the field more knowledgeable.
Yeah, and so that's where we've really gone back and forth, and I think that's where we're going to have to rely on our county extension agents, particularly for the workers. The supervisors and the foremen, they tend to be immigrant workers, right? They've moved to the US. And so our thought is maybe they are our train the trainer. We train them really well. And then as part of this, we have relationships with the farm owners. They're really good at working with this organization. So then we come in and say, okay, we've trained all your foremen and your supervisors. Can you have them sit down and train each group of new workers that comes in? We're still trying to work out the logistics of that just because it did. We thought we had a plan and then 2020 happened and COVID kind of derailed us, but that's on the horizon and hopefully we'll be out in a couple of years of what we end up doing.
Okay, thank you.
Sally?
Dan, do you see a lot of issues with drugs and alcohol? I'm just saying this because I worked with Project de Salud in Kennett Square long time ago. I guess a few years after I became a nurse practitioner, and that was, the lifestyle in terms of being alone and the hard work and all that kind of stuff. It sort of tended to be a problem amongst this group of workers. And I'm just wondering if you see that in your clinical practice.
Yeah. I see it, and I see it more so whenever I was out in Kennett Square. I did not see it as much there, but it's definitely a thing in South Georgia. And I wouldn't be surprised if we found the right population in Kennett Square, right? But in South Georgia, these workers are often isolated from their families for months at a time. They have access to cheap beer. We know that cocaine and methamphetamine are used on some of the farms. A lot of the farms have buses that will bring in sex workers just for the men. Yeah. And it's a really interesting coping mechanism, right? Of being away from your family and how you kind of will say you go and you're looking and there's the Catholic altar to Virgin Mary on the farm, and then kind of off to the side, it's like, oh, that's the bus with the sex workers, right?
Right.
So we saw all of that.
Yeah, well, I'm wondering if in Kennett Square that they've been around so long and there is a really strong Hispanic community now. And I think they've dealt with a lot of those issues to some degree. And I'm happy to hear that you're not seeing that in Kennett Square as much.
Well, and that's another question that we ask, because we always struggle. We have our migrant clinic farm worker partners in South Georgia that are there year round, right? And we go down with our students and we're functioning as an extension of them. We can make referrals to the clinic if we notice that someone's got an acute need and they need care that we cannot just provide them in 2 weeks. However, our issue is, again, all of these workers are paid by the piece. And so if they take time off to go to the clinic, they're not making money. Right. And so we've gone back and forth for many years of, well, do we screen with a PHQ-2, with the GAD-2 for depression and anxiety? Because if they score positive, we can refer them to the clinic, but are they going to go?
Right.
So it's something we're constantly thinking about.
Yeah, I'm sure. Well, thank you. Thank you for your presentation. It was wonderful.